All right, it's time for us to do our Kegel exercises. Why do we do them? Who cares? Well, the reason is that our pelvic floors are very important for our health. Our pelvic floors hold up the organs of the pelvis, including in women, the uterus, the vagina, the bladder, and the rectum. And so the stronger you can make your pelvic floor muscles, the better you can support them.
I like it. So then we have this patented GynoCast, customized Kegel exercise. World-renowned, custom.
And acclaimed, prize-winning.
We sound super fancy when we talk about it like that.
That's right.
But you've come up with this great routine that we can use to help strengthen our pelvic floor.
So easy.
Right. So you ready to start it off?
I'm ready.
Okay. 3
times a day.
6
days a week.
9
seconds per Kegel exercise.
And 12.
Kegel exercise in a row for a rep. And so you're just doing it 3 times a day. Do 12. Hold it for 9 seconds. Okay, you can do it 6 days a week and take a day off. You'll have a pelvic floor like a chain link fence, Twila dang.
I like
You'll
it.
be able to pull a trailer. You will be the envy of your neighborhood. You will walk taller.
I'm going to go do them right now. I'd like to walk taller today. So make sure that you're doing them, and feel free to go get that infographic off of the GynoCast Facebook page and share it with your friends as well. Stay tuned.
Hello and welcome back. You are listening to the GynoCast. My name is Dr. Eric Heegaard. I am a board-certified obstetrician and gynecologist, and I'm here with my wing person, woman.
I can be a wing woman. I'm okay
Twila
with that.
Twila dang. Or I'm her wing dude. One of the two.
You could be a wingman. It's okay.
And if you are new,
wait
welcome.
a minute.
Wait.
Okay,
what?
I'm married. I don't need a wingman.
All right.
That's not appropriate.
What am I then?
I mean, I can still be your wing woman. That's good.
Okay.
We'll put you out there.
I'll just be your, I don't know, spirit guide.
Wow. I think we rethink that one a little bit. It's all right.
I like that.
How about we just be like, I don't know.
Let's just be compadres.
Hey, I'm all right. We can be
compadres.
Compadres. Okay, I'm okay with that.
Okay.
All right.
So if you're new to the GynoCast, welcome aboard. We really appreciate it. If you are a repeat listener, we appreciate you as well. We talk about things that need to be talked about, and sometimes people don't know where to go. And today we are just going to jump into it because we have a lot to talk about. And we are very lucky that we have a guest, Dr. Matt Bigus, who is now a veteran of the GynoCast. Dr. Bigus, thank you so much for joining us.
Thank you for having me back. I appreciate it. It's always a lot of fun.
Good. Twila, is everything okay? You were kind of...
No, well, listen, okay, we're going to say this one time because we've made it this far without saying it. Don't tell the people how the sausage gets made.
I know, but you were making some sounds that made me think maybe we need to start over again, and I didn't want to just...
No, I was just checking. I'm the de facto producer. I'm making sure all the knobs and buttons are working properly. If they're not, I will stop you.
All right,
but
well,
in the
don't
meantime,
make
keep
any
going.
disturbing sounds then.
Okay, so no screaming in the background.
Screaming in the background.
Okay, just checking.
Dr. Bigus, thanks for coming back. I'm going to just introduce Dr. Bigus briefly.
Mm-hmm.
He is our newest member of OB/GYN West, which, for people who don't know, is the finest obstetrician gynecologist group in the universe. It's true. If you live in the metro area, the Twin Cities, St. Paul, there's no better place to go for your care. And so Dr. Bigus is a Eastern boy. He is originally from Reading, Pennsylvania. Went to college at Westchester, correct?
Correct.
Went to medical school at Drexel.
Correct.
And did his residency in Hershey, Pennsylvania.
Yep. Southeastern Pennsylvania, born and raised.
So let me just ask you this. Philly sandwiches, are they as good as I've been to Philadelphia briefly?
D'Alessandro's.
Mm-hmm. What's their key?
So there's a lot of different debate about which one to go to. Most people think Pat's and Gino's. They're the most widely popularized. I prefer D'Alessandro's. It's out in Roxborough, one of the kind of off to the side.
Mm-hmm.
By far the best meat and cheese and bread that you will get.
Because it's a combination of all of it. And
you can't just have one. You have to have all three put together.
Yeah, because if you have weak bread, not wheat bread, but weak bread, if that's a weak link, that's not good.
It destroys the integrity.
Mm-hmm.
And
now, mind you, we're from where my people are from, not from Philly. We're Pittsburgh people, so we don't even have.
You are not from Pittsburgh.
We don't.
You are from Virginia.
Okay, Colonel Sanders, put that accent away. We're Middle Pennsylvania folks, so we don't even traffic in Philly cheesesteak. We
It's like one layer. You think you know you?
Yeah, so you got to go.
You
got to go Permane Brothers with the coleslaw and the French fries on the sandwich, like bigger than your head.
Is that right?
Yeah, it's perfect.
Wow.
I don't even eat them anymore. I
still,
yeah,
absolutely.
You have to do it once. Yeah, you have to do that at least once.
So if you want more information on Pennsylvania, you can contact
it'll
Twila
wind up in the
Day
syllabus.
and,
Watch. We're going to at least have the
Dr. Matt
sandwiches
Bigus.
listed in the syllabus this week.
I will also say that Dr. Bigus was the chief resident of his class, which means he was either the dumbest or the smartest of his class. That means that he was in charge. He
was smart enough to be at the top, but not clever enough to get out of the way of the administrative work.
I always like how that kind of work. That's absolutely
that's
true.
very good.
I know. I spend most of my life trying to dodge administrative work.
But you can't help it when you're good at it. Okay, so today we are going to talk about prenatal care, which is the care of pregnant women. And why do we do it? Because a lot of people, there's a lot of mystery. And if you're pregnant, if you've been pregnant, maybe it's not a mystery. But if you're not pregnant, or
you're
don't
thinking
know anybody,
about it.
You're thinking, why does it matter? This is all natural, right? It's natural. And so we're going to talk about why this matters, what we're trying to look for, what we're trying to prevent, and that sort of thing. And so I'm going to give you a little historical trivia. You ready for this, Dr. Bigus? I like to put Bigus on the spot.
Yes, he does.
That could be a segment. Bigus on the spot.
Oh boy.
We can have a recurrent theme. Bigus on the spot.
I can get music for that, so no worries. I got you.
I like that. We're going to do that. Bigus on the spot. Okay, so
here we go.
Let's just imagine you are in Rome, let's say 50 CE, Common Era, right?
Okay.
You are at a convention in the Colosseum for pregnant women. You're just one of and there are 1,000 women there, right? You're sitting there chatting, laughing, expectantly thinking about your pregnancy and the excitement thereof. And now fast forward 9 months and a little bit more. Let's say 9.5 months, a couple months after pregnancy, you've delivered. How many of those 1,000 women will still be there? Alive with a pulse is what I'm saying.
200.
Oh, God, it's not that bad.
Yeah, I would say 60%.
No, it's actually, you guys are really grim. It actually was about, there'd be about 850 still there.
Oh, pretty good.
So there's, it's well, you guys are grim. My Lord.
I like living in the time I live in.
Yeah,
I love modern medicine. So I just assume it's just not going to be as good as it was here.
So you're sitting in the Colosseum, 9.5 months later, you will find that there aren't 1,000 women there. There are now 850.
Okay.
And so fast forward 2,000 years or so. Now we are in the 2000s, and you're in a Colosseum in the United States with 1,000 women who are pregnant. And at the end of their pregnancy, and let's go a couple months beyond, how many of those women will still be there? 980. That's actually pretty good. We did a show on this. That's why you know. Yeah, so so we've gone from what they call maternal mortality of historically it was about 150 per, or I'm sorry, 1,500 women per 100,000 live births. So it's per 100,000 births. So a death rate of about 1.5%. And now we are at, in the United States, 26 per 100,000. Yes. That's awesome. It is.
That is. It's remarkable.
Absolutely.
And the reason why this is so great is that these are, we're talking about young women who have whole lives ahead of them, productivity, et cetera. Women matter, we like to think here in the United States. Well, I'm just going to put some, qualifications on this, which is, what is it in Finland? So let's again, Dr. Bigus, I'm going to throw this. So in the United States, the maternal mortality rate is 26 roughly per 100,000 women. What is it in Finland, Dr. Bigus? Twila, I know you know this.
I know, that's why I'm not answering.
Right, I believe Finland's actually a little better.
It is much better, Dr. Bigus. It is about 4 women per 100,000. So in the United States, 26. In Finland, it is 4. In Canada, it is 7. So higher than Finland, but about a third of what the United States is. So we have got some work to do. And the sad thing, the frustrating thing, is actually in the United States, we spend more money on medical care than anywhere in the developed world and anywhere in the world. Our maternal mortality rate has gone up in the last 20 years, as opposed to everywhere else, which has gone down. And Texas, I hate to bring out our friends in Texas, has the highest maternal mortality in the developed world. The highest. It is over 30 women die per 100,000. It's tragic.
It is.
It is tragic.
Absolutely.
And to make it even more unfair, black women who make up 11% of the population make up 20%, 28, almost 30% of the deaths. So it is not distributed equally.
No.
And so the reasons for that are for another show, and we've talked about this, and nobody really knows. But
you can refer back to our playlist.
Yeah.
There's some other episodes where we address that a little bit more head on.
Yes. And so, in the United States, maternal mortality has more than doubled in the last 20 years. And so we've got a lot of work to do. And so why is that? Well, pregnancy is not a safe state for women. It has never been. And we've talked about if you want to go and have an interesting perspective on an afternoon off, go wander in a cemetery from 100 years ago. You will find women and babies. Well, of course, everybody's dead from the night. Right, Twila? 1850. I know the overall mortality rate is 100%.
Yes.
But, if you want to look, you will see young women and babies. And so this is why we do what we do is, Dr. Bigus and myself and people in our group, we take care of pregnant women because it matters, and it's not a safe state, and it never has been, although it's safer than it was. So, Dr. Bigus, can you take us through kind of what we do with prenatal care from what we are looking at? Because people find it, and most women are happy to do it, but many people, including their partners, sometimes find it annoying that we are bringing them back, sometimes for not very long. They wait around, and we're looking for certain things. What are they?
Sure. So let's start from the beginning and work our way all the way through. So right from your first menstrual period all the way up to it's time for delivery. Pretty much most women find out that they're pregnant when their menstrues are a little late, and they use a home pregnancy test and find out that it is positive. Usually after that, we'll get a phone call, and we'll ask them to come on in, usually after obtaining some blood work and getting an ultrasound. And when we do this, what we're looking for is some baseline information on both mom and the timing and dating of her pregnancy, because where exactly she is in her pregnancy is very important to us, because it helps us identify a proper due date, identify the growth and well-being of the fetus, and sort of where mom is in her changes of her pregnancy throughout. Normally, we'll wind up getting an ultrasound somewhere around 6 to 8 weeks after conception or your last menstrual period, in order to verify that you do have what we call an intrauterine pregnancy, meaning a pregnancy within your uterus where it belongs.
And that's important.
Yes, it is. Because there are a very few % of women who do get pregnant that the pregnancy is outside the uterus, and that is an ectopic pregnancy, which I believe we'll be speaking about later.
Yes, that's a different show, and so look at our website for that.
Mm-hmm.
So that ultrasound is very important for us to determine that you have a pregnancy in a safe location where most of them are. In addition to that, it also helps us to verify that your last menstrual period is correct with your dating. Some people do not have regular periods every 28 to 31 days. Some people can skip a month here or there, or may have some bleeding that is from implantation, which they think might be a menstrual period, and their perception of their last menstrual period may not be correct. In addition, some people just don't really regularly track their periods, and we see that very often, that we get people who say, honestly, I know it was in February, but I don't remember when exactly it was. And this ultrasound helps us to really identify where you are in your pregnancy and how to move forward.
If I were a woman, I would never know when my period was.
Oh, you'd know.
Well, I'd know when I was having it. I'm not in a coma.
No, I mean, for the most part, even if you just have a ballpark, because there's just sort of that, like, wanting to know the onslaught is coming.
Well, I guess that,
you try to keep up at least a little bit.
All right, Dr. Bigus. My job here is to try to distract Dr. Bigus, so he has to stay on his toes.
So after the ultrasound, usually you get some blood work. The blood work helps us identify a few things. We're looking for some very basic things, such as your blood type, which is very important, not necessarily in your first pregnancy, but in your subsequent pregnancies. We're also looking for other things, some basic screening tests for venereal diseases such as HIV, such as hepatitis, such as syphilis, which is pretty standard across the nation, to verify and make sure that there is no abnormalities that may cause some significant changes in the pregnancy. We're also looking for complete blood counts, platelet levels, and a few other things in order to make sure that you're starting your pregnancy in a healthy state. And there's not something at the beginning of the pregnancy which is going to cause us complications later as things progress along. Then you'll come and you'll usually meet with a nurse or one of the physicians at your very first appointment. And at that appointment was usually when we review all your medical history. It's very important to make sure that you talk to your physician, your obstetrician, about all your medical conditions, all the medications you're taking, including over-the-counters, herbal supplements, and vitamins that you're taking.
So when you say all, do you mean like anything? Like, oh, I have teeth problems, so I'm always going to the dentist.
Yes.
Because I think sometimes people think that the doctor's information is just for doctors, that OBGYNs only need to know information from below the waist, that dentists only need to know what's going on in your mouth, and we don't really communicate across to each, depending on what
right.
it is.
It's very important that you let your obstetrician know right away in your pregnancy everything that's going on with you at a medical standpoint, because even things that aren't necessarily gynecologic in origin can cause significant issues and need to be addressed during the pregnancy. For example, you bring up dentistry. Unfortunately, people with poor dentition or those who need a lot of dental work, they oftentimes can have some complications later in the pregnancy with things such as preterm labor and other issues like that. So we do ask that you talk to us about all of your medical conditions in their entirety, and especially all your medicines that you're taking, to make sure that what you are taking is safe in pregnancy, and to make sure you're taking the right supplements that you need during your pregnancy.
Do topical medications count in that sort of medication list?
Yes, they do. So everything you get prescription-wise or any supplements that you take.
Herbal supplements,
Yep.
Alternative medicine things.
Correct.
I want to know about that.
Because there are some things that people can do in pregnancy which are not necessarily safe. And instead of going through that exhaustive list, it's a good thing to bring up with your physician to verify that what you're doing is okay during pregnancy. And then during that appointment, after reviewing all your medical history, you usually go through a physical exam. The physical exam is usually head to toe, includes a breast exam and a pelvic exam. And if you haven't had an ultrasound before, some places will do your ultrasound right there in the room in order to verify that the growing baby is still alive in your uterus and we can identify a good, strong heartbeat. That physical exam is very important because we're looking and screening for any conditions. It's oftentimes one of the start points where people find out that they have a lifelong medical condition is during a pregnancy, during that initial physical exam, because they may not have had regular care prior to, or necessarily have seen anyone since their pediatrician until they get pregnant. It's usually at that time that some medical conditions will get picked up by your obstetrician at the beginning of the pregnancy, and those can start to be addressed and cared for to make sure that they are well controlled both during your pregnancy and afterwards. Breast exam is very important because your breast will go through many changes throughout the entire pregnancy as the progesterone levels increase and your breasts change and get ready for breastfeeding. In addition, the pelvic exam is very important. That allows us to make sure your pap smears are up to date. Pap smears are a test that is a screen for cervical cancer. We make sure that everyone does have a healthy cervix during their pregnancy. And if there are any precancerous changes, that those are addressed during the pregnancy. After that full physical exam, including an ultrasound if necessary, usually we ask you in the first trimester to come back about every 4 weeks in order to make sure that things are progressing well, to evaluate how you're doing in the first trimester, especially with that nausea and vomiting that oftentimes occurs. We also are looking to make sure that you're not having any issues with vaginal bleeding or cramping early in the pregnancy, because those may be signs of a miscarriage or what we'd refer to as a threatened AB.
Support for the GynoCast is provided by OBGYN West. OBGYN West provides the highest quality care from compassionate providers, including women's health issues from general sexual health to pregnancy care, childbirth, menopause, and beyond. Whether it's your teen's first annual exam, a new baby's on the way, or you're facing the special challenges of middle age, OBGYN West provides a wide array of services. Their doctors and PAs are trained in virtually every type of OBGYN service and procedure, OBGYN West provides exceptional care for women.
Before you go on any farther, I just want to ask you a couple of questions, and that is, can you talk a little bit about some of the physiologic changes that happen in pregnancy, just briefly, and what we're looking for? So, for example, you said that there's a lot of breast changes and that sort of thing. Can you talk a little bit about just briefly what happens to the heart and lungs and that sort of thing?
Sure, absolutely.
In pregnancy.
So, addressing those specifically, the heart is going to start to accommodate an increase in volume over your blood. So as a pregnant woman goes on, your body is going to change and allow for you to support both the pregnancy, increase your blood flow to that growing uterus and the placenta, and in addition get ready for delivery where you're going to have an expected large amount of blood loss. And as your body changes for this, it increases your blood volume, and your heart has to work harder and pump the blood harder throughout your entire body. Because of that, your blood pressure will change and your heart rate will change as well. Heart rate usually will tend to trend upward a little bit, and then your blood pressures will tend to trend downward a little bit. Part of this is because your body has a compensatory mechanism where your blood vessels relax slightly throughout your entire body. That allows your heart to push the blood easier throughout your entire body and get it to the uterus and the placenta to help perfuse and give all the nutrients and oxygen needed to the baby. With this is oftentimes what we'll see is that swelling in pregnancy that almost every woman does experience. As far as your lungs are concerned, the lungs are going to work harder. They're going to have difficulty expanding because of the growing uterus. So because of that, the lung changes in its dynamics. Your breasts might increase a little bit, and they'll definitely increase in the amount of lung tissue that you use to recruit to oxygenate your blood.
Okay. So these are some of the things that we're taking into account as we're seeing women for their prenatal care. So as you were saying, we're seeing people every month or so up until kind of mid-pregnancy.
Mm-hmm.
And during that time when they come in, we're checking their blood pressure.
Mm-hmm.
We're looking at their urine to make sure there's no protein and glucose.
Right. So what we're doing is with the blood pressure, we're making sure that you maintain a healthy level. Your blood pressures aren't dropping too low, which very rarely happens, or more concerning, your blood pressures don't start to trend upward. One of the most common things that we look for with blood pressures is that pressure does tend to elevate. And we do have a threshold, sort of a line in the sand that we draw, where if it's above a level of 140 systolic or 90 diastolic, that becomes a blood pressure that is too high in pregnancy. And then we start to get into a disease of pregnancy that's common called the preeclampsia spectrum. This spectrum goes from anywhere from the most mild form, which we refer to as gestational hypertension, to the most severe form, which we call eclampsia. So starting off with that very mild form of the preeclampsia spectrum, or the gestational hypertension, is just a persistent elevated blood pressure over that line in the sand that we talked about of 140 over 90. If your pressures stay above this level, we start to monitor you even closer throughout the pregnancy for development of preeclampsia or worsening of this disease spectrum. So as things progress, we want to make sure that your pressures sort of stay at that smoldering high level and don't elevate beyond to what we consider a severe range in pregnancy, which is 160 systolic or top number and 110 diastolic or bottom number.
Dr. Bigus, let me ask, so what impact does this have on the baby?
Mm-hmm. So one of the problems with...
Why do we care, I guess?
Absolutely. So one of the problems with this gestational hypertension is, or preeclampsia spectrum, is it affects both mom and baby. With moms, your pressures can elevate to the point where we worry about stroke, we worry about...
we worry about seizures, we look at stroke.
Yep, stroke and seizures. And with the baby, we worry about, as the blood volume and the blood pressures increase, that the baby doesn't get as much nutrients and oxygen as they need. That oftentimes, over time, causes the babies to start losing growth, and they'll get smaller over time, and you'll start to get a baby that's called growth restricted. And long exposures to preeclampsia is, for the baby, most worrisome in that making them small. And small babies don't tolerate labor as well. They don't tolerate pregnancy as well. They oftentimes have a little bit harder start to life than a normally grown baby does. Now, one other thing that we worry about is with the placenta. If your blood pressures get so high, the pressures can force the placenta off of the uterus before the baby is born, and that's called the placenta abruption. That is a catastrophic thing in pregnancy that would need to have an intervention immediately for.
Like surgical.
So this is one of the things, as Dr. Bigus is discussing here, there's a few things that we are really looking for every time a woman comes in, and one of the things we are looking for is signs and symptoms of developing preeclampsia. Mm-hmm. Now, popular culture input here. Yes. Downton Abbey fan, Dr. Bigus, I could see you as a big Downton Abbey guy, big public TV, British kind of. Were you a Downton Abbey fan?
Nope.
Oh, Twila, for goodness sake. Well,
I knew about the show. I know about the show.
For those of you who love Downton Abbey, do you remember Lady Sybil?
Yes. I mean, I know the gist. I used to
Dr.
work.
Biggest Lady Sybil, everybody was in love with her. A kind soul. And she gets pregnant. Not a good marriage for those. It was a good marriage, but there's a little conflict because he was kind of a working class Irish guy, and she's a noble lady, right?
Right.
Well, in the middle of her pregnancy, she starts getting headaches, swelling up, developing preeclampsia. They didn't know what it was. The hometown doctor said, "You gotta operate. We gotta do a delivery." They invite this fancy obstetrician from London who disagrees. Huge kerfluffle there in the small town. And anyway, Lady Sybil has this horrible seizure where she dies and the baby dies. And it is actually it's kind of hard to watch.
Yep.
But this stuff happened. Mm-hmm. And so for those of you who saw that episode and wanted to know what they were talking about, this is what we're looking for.
For those of you who haven't started Downton Abbey, spoiler alert. Too late.
Oh, God. That was like 3 years ago. If you're that... She's kind
we have that debate all the time.
I'll tell you, can I just say, she was kind of an annoying character, just a little bit. She was too sweet. She was just like saccharine. Never did anything wrong, except for marry I guess she did run away and marry this Irish guy, which upset everybody. But anyway.
But in that setting, that's for love. That's different.
That's right. And you see how it worked out.
Well.
So, Dr. Bigus, preeclampsia, we're looking for that. At 28 weeks, we check glucose or blood sugars because we're looking for
gestational diabetes. So gestational diabetes is also another very common issue in pregnancy that occurs. And what's really happening is your placenta is secreting a hormone called human placental lactogen. This hormone goes throughout your body and causes a peripheral resistance to your own insulin. That causes you to have a slightly elevated blood glucose level. Now, your body compensates for this because the placenta and the growing fetus absorb so much glucose into it that you have a normal blood glucose level. And that seems a little counterintuitive, but if you have a hormone that increases the absolute value of the glucose in your blood, and you also have the placenta and the fetus drawing an increased amount of glucose out of your blood to help to grow, then you should say about the same levels as a non-pregnant person. Mm-hmm. So in gestational diabetes, what we're looking for that balance between how much glucose that your body is having flowing through your bloodstream as a result of that human placental lactogen, or HPL, and balancing that with how much the uterus is absorbing through the placenta for the growing baby. Now, when those glucose levels start to have too high of a level, or that test that we do where we have you drink what we call a glucola drink, or a very sugary, almost looks like, if you remember those little
not
Huggies.
Fun orange soda drink.
Right?
Yeah,
Mm-hmm.
It's like, it tastes like drinking a flat orange soda that's really sweet.
Right. Mm-hmm. And we check your blood counts after that, and if your glucose levels are above a threshold that we use, then we confirm that with a larger test where you have to drink almost about 3 times the amount of that flat orange soda or the glucola, and we take your blood sugars over the course of 3 hours. Now, if all of those values are elevated as well, then we start getting into that gestational diabetes.
And why does that matter if a woman has diabetes?
Sure. So gestational diabetes primarily isn't going to necessarily affect the mother as much. It's more of a fetal issue of what we care about. Uncontrolled gestational diabetes really has 2 major things that I'm concerned about. Number one, most concerning, is an uncontrolled gestational diabetic has an increased rate of stillbirth in the pregnancy. And that, to me, is the number one reason why your blood sugar should be controlled during the pregnancy. Because if they're too high, you really are putting yourself and putting your growing fetus at risk for stillbirth, which is my number one thing that I try and want to prevent in a pregnancy. The second most important thing is babies who are exposed to increased glucose levels start to develop increased growth. This is something we call macrosomia. Macrosomia is a fancy way for us to say too large. So the babies are kind of at the top of that
It's
growth
a big,
curve.
chunky baby.
So when we see on TV and they're like, oh, a woman delivers 13, 14, 15-pound baby. That's You're talking like that range.
That would be macrosomia, so a baby that is entirely too large.
Okay.
Now, the biggest thing we worry about babies being large is twofold. Number one, difficulties with delivery. As babies grow larger, especially from diabetes, they have a tendency to put the weight on kind of more up towards the shoulders and then the neck area. So the shoulders, neck is disproportionately large compared to the rest of the baby.
They're husky.
They are absolutely husky, almost like a linebacker.
Right.
And after the head gets delivered...
You want to deliver a linebacker, Twila?
No. No, thank you.
Right, and you would imagine that after the head comes out with the big husky shoulders, they oftentimes get stuck. So the rate of shoulder dystocia or an impacted shoulder during a vaginal delivery goes way up. In fact, obstructed labor also goes up in people with macrosomic babies as well.
Meaning that we're going to end up having to do a C-section.
Correct.
Correct.
Let me ask you guys a question.
Sure.
This is more philosophical than anything else. You
All
ready
right.
for this, Dr. Bigus?
Yes.
Because I've noted that, Twila, you're like this too, but Dr. Bigus is exceptionally good at this. There's nothing I cannot ask him that he will not have an answer to.
I'm good
and
with
usually
that.
it's correct.
Unless
okay,
it's
so
about downtown
yeah, check down. He's not a big British public TV guy, I guess. All right, would you define the fetus as being a symbiotic relationship or a parasitic relationship?
Ooh. I think this all comes back down to how I feel about my children today. Let's see. Was it a good morning?
I know what I think. I'll tell you that.
I guess I mean, I'm going to get emails, but I honestly feel like it's more parasitic.
I happen to think it's more symbiotic.
Do you
yes,
really?
I do.
See, I was going to say parasitic. And
Well,
you know, the
that's
mother
what you would
produces.
think.
I know. Okay, so I want to hear what you have to say. But so the mother produces all this stuff. She produces extra, glucose because she's diabetic. And what does that baby do? It doesn't get rid of the glucose. It just goes and feeds at the trough like I do when I know there's some Ben and Jerry's vanilla ice cream. It's like I can't stop eating it.
Right.
Which is why I've got husky shoulders and a big head. All right, so now, Doctor.
Now I want to hear Dr. Bigus. So why do you
Dr.
think
Bigus
it's
feels differently.
Yeah.
It's a very philosophical answer, meaning that in pregnancy, the growing baby doesn't necessarily do any wonders for your body, doesn't make you necessarily going to be healthier, but you get out of this a child. And most women will tell you,
Man.
yeah.
I want to hug you right
No,
now.
I know.
I don't. I'm going to counteract this whole argument.
You
Because
know what
I have
he's like?
3 of them, and I love them dearly, but still stretch marks.
For those of you, we don't have the. And if you want more information, Twila, if you want more information on Dr. Bigus, where should they go?
We'll make sure we have it up on the syllabus on the website. So for every episode, we do a syllabus. We kind of hit on the things we've talked about, and I promise you, the syllabus is comprehensive. It's not just the medical information we're talking about. At the top of the show, we talked about sandwiches. I'll put the links to the sandwiches there, so you can find those things.
Yep, absolutely.
So you'll definitely be able to get connected to Dr. Bigus and how to get in touch with him through there.
You know what we need to do? Is a Pennsylvania food tour. We'll have you, Twila, you, Dr. Bigus. We'll go on a
East and
tour.
West.
I'm just.
This is awesome, and we'll film it. So for those of you who don't, you can hear Dr. Bigus. If you go to our website, you can see some pictures. But I'm going to just describe him. Please don't.
Boy,
I hope
here
you're
we
not.
go.
Well,
offended.
you don't have to because I took a photo the last time we
but
filmed together. It's going to go up with the behind the scenes
A photo
stuff
is
on the
very,
website.
very different from the man.
Okay.
And I will tell you.
I'm sorry. I don't usually
I-
disclose that I take your action pose when you're recording with us, but I usually do.
One of the criteria for being on the GynoCast is you got to know what you're talking about. You got to be cutting edge, and you got to be a good egg.
Yes.
And so Dr. Bigus fits all that. He is a good egg. He's a good soul. But beyond that, I will tell you this, and you're going to hate this probably, but
All
your
right,
wife
here
would
we
agree. You're cute. And I don't mean cute like in Brad Pitt. No, and you're not, because that's more.
Wow.
No, but you're, Brad Pitt.
Wow. You just got downgraded to like puppy status.
Cute,
you know that?
But a face for radio.
Yeah.
No, but Brad Pitt, some people say he's cute, but he's more kind of cut, kind of sharply angled. Bigus, I got to tell you, you are like a kind of a swarthy teddy bear.
What?
I want to hug you. I can understand why
He has now said
married
twice that he wants to hug you.
Wow.
I feel
All right,
like that's a compliment.
Yeah.
You're always sitting very close to him, though.
A swarthy teddy bear.
Please get that
Would
on
you
a
prefer
T-shirt.
I said hirsuit?
Listen, please get that on a T-shirt. I'll sell it.
You'll find more about hirsutism when we talk about polycystic ovarian
Yeah.
on a different show. So, again, we were talking about gestational diabetes. We talked about polycystic about preeclampsia. We're now these things tend to happen more as we get into the mid-pregnancy and we're moving on. And so as we're getting beyond kind of the 28, 30 week sort of standpoint, what are we looking for? We're seeing people every 2 weeks now and then every 1 week. What are we doing?
So we're doing surveillance for a lot of the same things that we've already done. We're surveilling your blood pressures. We're surveilling your weight, making sure that you have an appropriate healthy weight gain. We're checking your urine to make sure that you're not spilling glucose, which would be a sign of gestational diabetes, or spilling too much protein, which would be a sign of that preeclampsia, which we briefly touched on. And then the other thing that we're doing is we're measuring your belly, making sure that you're growing appropriately, making sure that the baby's not too small, meaning you're measuring too small down or measuring too large, which could either be macrosomia or another condition which we call polyhydramnios. Polyhydramnios oftentimes is very common in pregnancy as well, and it is too much fluid that surrounds the baby. Basically what this is if you take all the women who have polyhydramnios, about half of those women, unfortunately, we never find a reason as to why they have an elevated fluid level around the baby. A quarter of those women is from gestational diabetes, and then the last quarter is usually from some other things such as some genetic abnormalities, difficulty swallowing, or other serious issues with the baby, which we normally will be able to pick up prior to finding out that your fluid levels are too high.
Now, I guess I didn't think that having too much fluid around the baby was an issue per se.
It absolutely can be. We kind of have once again, another line in the sand of when we measure your pockets of fluid, we want to measure nothing greater than 8 centimeters. And if it is greater than 8 centimeters, then we start worrying about that excess fluid. Now, the excess fluid doesn't necessarily cause any issues with baby, but can definitely cause some issues with after delivery. You have an overdistended uterus, and an overdistended uterus has a tendency to not want to clamp down after delivery as well. Because of this, you can have some pretty bad bleeding and some hemorrhaging after delivery of the baby from polyhydramnios. In addition to this, when your water does break, if you have too much, that large gush of fluid that comes out could actually rush out with the umbilical cord as well. So these are a lot of things that we worry about with people who have elevated fluid, as well as trying to figure out why exactly they have elevated fluid. We do know that those babies are a little bit more at risk than babies with normal fluid. So we tend to check on these mothers a few times, usually about twice a week, with what we call non-stress tests and with quick fluid checks with an ultrasound.
So one of the things, we're now getting close to delivery, and that'll be a different show. We're going to talk about, the actually delivery of the baby, labor itself and that sort of thing.
Yeah, absolutely.
But, in short, I'm going to kind of summarize a little bit about what kind of a bigger picture thing, which is early in pregnancy, we're trying to see if there's risk factors that will affect the pregnancy as it goes along, if they're at risk for preterm labor and that sort of thing. When we were trying to there are tests that we can do to see if the baby is normal, chromosomally and anatomically and that sort of thing. As we move into the middle of the pregnancy, we're especially worried about preterm labor. And so we're looking for signs and symptoms of that, as well as development of preeclampsia, as Dr. Bigus was talking about, diabetes and that sort of thing. And then as we move towards actual delivery, we're looking for something that suggests either the mother is not tolerating pregnancy or the baby's not tolerating pregnancy. Because at that point, we're thinking, is the baby safer outside than inside? That's the question that we're always asking each other and asking ourselves as we're moving close to delivery.
Okay.
And so we're looking for signs and symptoms of that. And that's what Dr. Bigus is talking about, whether we're looking for excess fluid, development of preeclampsia, diabetes, and other issues. So I'm going to fast forward just a little bit here, Dr. Bigus, because we're going to, boom, you have your delivery. Ready?
Mm-hmm.
So you've had this lovely baby, either by C-section or vaginal delivery, and now we're in the postpartum time.
Mm-hmm.
You've gone home, you're coming back. What are we looking for in terms of that postpartum time, that in terms of physiologic changes and things that we're concerned about?
Right. So normally after you deliver and are discharged from the hospital, we usually, for a healthy mom, ask to see you back at about 6 weeks. And during that 6-week period of time, you'll go through some significant physiological changes, kind of all the reversal of what you experienced during the pregnancy. Your uterus starts to shrink back down to a normal non-pregnant size, which is about the size of a pear. Your body starts going through
a Bartlett.
There you go. Just a pear. I don't need it to be a specific kind.
Sorry, doctor. I don't mean to disrupt you. Yes, I do. Yes, I do.
So other things that we're looking for normalization of blood pressures, especially if you've had issues before. We're looking for make sure that you're having healthy changes with your breasts, because most women are still breastfeeding at the 6-week period of time. In fact, we do recommend that every woman, if able to, continue to breastfeed for up to about a year, if possible. We review that, and we review to make sure that your body has been going through those changes appropriate to resolving the pregnancy by doing another physical exam, head to toe, kind of making sure that everything is good. One of the important things that we check on, too, at 6 weeks is make sure that your mood is okay. A lot of women undergo some significant mood changes after the baby is born. And these aren't necessarily because of anything is wrong with the baby or wrong with mom or there's stressors at home. While stressors at home may contribute to risk factors, but just by involuting the uterus and changing that physiology of pregnancy, you go through some chemical changes and imbalances in the way that your neurons work inside your brain, and that oftentimes will cause a fleeting, transient mood changes where women start to, get down in the dumps, get what we call the baby blues, which normally resolves in a couple weeks. If we start seeing you at 6 weeks and you're still having symptoms of depression, feeling down in the dumps, feeling like nothing is enjoyable anymore, having difficulty sleeping, having difficulty eating, not being able to keep your concentration, or God forbid, thinking about hurting yourself or hurting others, well, then that's something that we would definitely have to intervene about. We also review any other specific medical conditions that you may have that's unique to you and make sure that things are improving after pregnancy.
Now, can I ask you a question? So we, earlier on in our podcast, you were talking about preeclampsia and diabetes, and what bearing does that have in terms of long-term health?
Sure. So preeclampsia, the one thing that we worry about a lot is people who have preeclampsia are at increased risk for later in life to develop hypertension and cardiovascular disease. Because of that, we want to make sure that your blood pressures do normalize after pregnancy, and then we encourage you to keep a close eye on your blood pressures and cardiovascular state of health for the rest of your life, because you will always be at increased risk after having preeclampsia. Some people do not have normalization of their blood pressures and will need to be started on medications that may very well be lifelong.
And gestational diabetes.
Right. So gestational diabetes, people who have that are much, much, much more likely to get diabetes. In fact, by the age of about 50, if you've had gestational diabetes, you're about 50 to 60% likely to have regular gestational diabetes type 2. In life. So for those people who suffer from gestational diabetes in pregnancy, we do another glucola test at 6 weeks postpartum to make sure that you have resolved those issues and you don't have a continuation of that diabetes after pregnancy.
And they're going to have to be aware of this for the rest of their life.
Absolutely. Yes, they are. Even if it does resolve, you still have to keep that in the back of your mind, and with your primary care physician, keep a close eye on this and make sure that you're being screened for development of diabetes throughout your life.
So, Dr. Bigus, thank you very much again for talking about this. I hope people have gotten a better sense of kind of how pregnancy is not a normal or safe state for women. It causes huge stress to the woman's body, and the reason for your prenatal care is we're looking for certain things.
Right.
And so just a little topical thing, I'm just going to talk about the importance of being aware of healthcare changes that may be impacting on funding for women's health, talk to your. Just be aware. Educate yourself.
Education is good.
Look, and because it matters. Women's health care matters, and we don't want to be at the lead of the industrial world's pack in terms of maternal mortality. We want to be at the back end.
I agree with that. I agree.
Do you want to talk about that?
Yeah, I just want a quick plug. We'll try to put a link into
the
podcast.
Yep.
But there's an excellent resource that you can get from. It's published by the American College of Obstetricians and Gynecologists. It's called Your Pregnancy and Childbirth. It's a month-to-month comprehensive guide. It answers just about every single question you could possibly have in your pregnancy, and it is an excellent resource for mothers to get to help them sort of guide themselves through what's going on and be able to answer a lot of questions that they may have.
Would you choose that book, say, in place of the good old reliable What to Expect When You're Expecting?
Be honest with you, I haven't read that one per se.
That is the gold standard that all the moms give the other moms.
With a girlfriend's guide. And
right. But it's really just the, like, you go to the bookstore as soon as you're pregnant and somebody goes, get that one because it'll tell you what happens to you month to month. But it doesn't necessarily come from, I think the woman that wrote it is, I think she was a nurse or she is a nurse, but it's like a handed down. Right. It's at this point, it's like chicken soup for the soul. We all know it.
So that, speaking of that, go to our website, look for our shows, because we're going to be doing a show on labor and delivery. Also, if you're not a member of the Facebook group,
yes, you need
to
go
join the GynoCast Facebook group. It's life-changing.
Yes.
Twila was a shadow of herself before being a member of this. And
mere shell. So if you're going to go to
pressure,
go to the Facebook page,
Jeez.
Go to Facebook, search The Gyno Show. Type that in. It is a private group. We need you to join the group if you aren't already a part of it. Once you join the group, you can be a part of the discussion. You can make suggestions for future episodes. You can even have the option of asking us questions. There is a send message feature on that page. So you can click on that and you can send messages to us. If you need it to be more anonymous and more private, you can do it that way. If not, you can just post it on the direct page. Dr. E will always go through and answer your questions well before they ever get to podcast level. But this way we can actually get the information out to you quickly as possible, and you can get your concerns addressed in a timely fashion.
And look out for our new side episodes called Time Out with Bigus, where we'll see how Dr. Bigus spends his off time. We'll talk about we'll cook together. We'll exercise together.
I'll get you a contract. Don't worry.
Yeah.
We'll make sure we get that all signed out.
Don't you think that's a great idea? Time Out with Bigus.
Okay. I have no problem with that.
I will bring Pennsylvania Dutch traditions to Minnesota.
Wowzers.
There you go. I'm not sure what that means, but I'm kind of excited.
I do. That's interesting.
Oh, you do?
Sure.
All right.
Indeed.
Now, can I say thank you for listening?
Yes, you can say thank you for listening.
All right. Thank you for listening.
Okay, we'll see you soon.